So, dear audience, first a big thanks to the organizers for inviting me to this meeting, which from what I've seen and heard about this conference, and will mark a new start for strategies and actions to combat health inequalities in the Nordic countries. I hope that we are all here today because we share this common ambition, because inequalities are on the rise in the whole world, and including in the Nordic countries, both with respect to key health determinants, such as living conditions, income, wealth, and childhood conditions, and consequently also with regard to health inequalities. So in this presentation, I will explain why I think social inequalities in health are unacceptable. I will tell you some of what we know about this phenomenon in the Nordic countries. I will mention some of the explanations that have been put forward, including from my own group. And I will reflect on what can be done to buffer them or even reduce them, if even possible. Now, the Nordic countries, they are very similar, of course, in terms of their social structure, in terms of their culture. And their long-standing commitment to egalitarian policies has made the Nordic countries a benchmark in comparative health research and social research. And these policies have achieved remarkable improvements in general health and mortality rates over the last few decades across all social groups, resulting in some of the largest life expectancies in the world for all social groups. But of course, we know that all social groups have not benefited equally from this improvement. And the absence of smaller health inequalities in the Nordic countries has often been presented as a public health paradox, against, of course, the background of the more generous welfare services found in the Nordic welfare systems. And this Nordic paradox has then given rise to an extensive body of research documenting socioeconomic inequalities in various health outcomes and possible explanations. Let's see if this works. Well. So, why should we be concerned with social inequality? Well, the study of social inequality is a premise for understanding and maintaining our welfare states and democracies, because it helps understand how the organization of our societies are linked to opportunities, how they are linked to attitudes, to behaviors, among the people that live in them. But there are some forms of inequalities that requires more than just our understanding. Now, health inequality is the most dramatic consequence of social inequality, which requires political will and action across several sectors. And may I remind you that this is not about a health gap between the rich and the poor. There is a graded relationship between the most disadvantaged and the most advantaged people, going from the bottom to the top, which of course has important policy implications. Universal policies should be the main strategy. Targeted policies should only complement these strategies. So therefore, let me answer my first question right away. Social inequalities in health, as presented in the Dahl review, you can see the review here, has presented these inequalities as a problem at many levels. It is a problem of injustice because people in lower strata, they are deprived of freedom, of health and life chances. It is a problem of living conditions because poor health is a source of social exclusion. It is a public health problem also because poor health is a source, because the health potential of populations are prevented from being fulfilled. There is a theoretical potential that is not met among all social groups. And it is an economic problem too, because social inequalities in health have consequences for employment, for economic growth, for public health expenditure, and ultimately for the economic sustainability of the Nordic welfare states. And it is a problem of well-being, because people with health problems and low status have less favorable prospects to their general well-being and quality of life. Now, when reduced inequality was added as the 10th SDG goal, it really placed inequality, and I would say social inequality, in the core of several policy and research areas. And this has, I think, resulted in a political and scientific interest in inequality, which has had several implications. First, I think it has enabled cross-disciplinary work, particularly between social scientists and medical scientists. And this is necessary because we need to know more about the smallest building stones and the largest building stones that may generate inequalities in health. And secondly, it may have had a consequence that almost all political parties now want to reduce social inequalities in health, although this may be for different reasons and with different priority. So this places us as researchers in a very historically unique position, because our research is now more policy relevant than ever, and our work is more important than ever. So what can the most recent research tell us about the magnitude, about the explanations, and about possible action points to reduce inequalities in the Nordic countries and beyond? Well, to address these issues, I would like to structure my answers according to the main pillars of CHAIN, which is a Center for the International Study of Health Inequalities, which I'm leading from Norway. And as health inequality researchers, our mission should be to monitor, to explain, and to provide evidence that can reduce such inequalities. All of these three. Now in CHAIN, for example, we work with the Global Burden of Disease study to monitor health inequalities. We work with academic institutions, also in Nordic countries, to explain these inequalities. And we work with UNICEF and other organizations that have field experience attempting to reduce inequalities in health. And please note that the following presentation will consider education as a measure of socioeconomic position, but of course there are other dimensions that could and should be treated as well, which is why intersectionality is one of the cross-cutting principles in CHAIN, as you can see here. So let's have a look at the solid facts. Now, this graph, or bars, show the relative inequalities among European men aged 30 to 74, measured in the period from 2005 to 2009. And as you can see, the inequalities in the Nordics are far from the smallest. And it actually seems to be a lacking association between the generosity of welfare policies on the one hand, and the magnitude of the inequalities in health on the other. Norway and Finland seem to have larger inequalities than Sweden and Denmark. Now this is for men. For women, the picture is in some ways similar. Norway has the largest inequalities and larger than most other countries, disregarding the Central and Eastern European countries. Now this figure stems from the Euro-GBD project that I led in Johan Mackenbach's team a few years back, and it really presents dots that represent 3 educational levels among men, using the same data that you have just seen, to highlight also the absolute distances between the social groups. And put shortly, the evidence for a Nordic paradox actually here still seem quite evident, as the inequalities are definitely not smaller than elsewhere, again disregarding the Eastern European countries. And Sweden seemed to fare better than the other Nordic countries. So what about trends? Now this may be a bit hard to read, but what I can tell you from this is that inequalities in health, in all-cause mortality, is increasing in the Nordic countries. This is our slides for men. The left bars present absolute inequalities, slope index of inequality, and the right-hand side we see relative inequalities, relative index of inequality. And at best we can say that the Nordic countries are placed at an average level, but the trends are increasing, so the pattern is not really promising. Among women, it even seemed to be a bit disturbing. Inequalities among Nordic women, particularly in Norway and Denmark, are among the largest in the whole of Europe. And these results are supported both concerning absolute inequalities and relative inequalities. So, what can explain this? What is actually going on? Well, according to, there are many explanations, of course, and according to Mackenbach, it may be that welfare states have not eliminated inequalities in material resources. So although the magnitude of income inequalities are smaller in the Nordic countries, and the prevalence of poverty is rather low, there are still substantial inequalities in income, in wealth, and housing conditions that remain. Another explanation that has been put forward is the educational expansion, combined with the fact that education is now even more important to obtain a higher income. And both of these elements play a role. Johan Mackenbach, he recently also suggested that it could be because higher educated seem to marry higher educated. So we see an accumulation of very resourceful families in our societies that make them in a more favorable position, which is increasing over time. An explanation that I've not seen yet, which I think is important, is related to technologies. So our own research in Chain has shown that technological innovations increase social inequalities in health because the access and use of healthcare technologies, lifestyle technologies, injury prevention technologies, they are first used and better used by people with a more advantaged position in our societies. So if the Nordic countries are more technologically advanced than other societies, then this could be part of the explanation. And there are other reasons too. So we could speculate, for example, that failing to be socially mobile in a country where everything is really set up to be socially mobile, this would be even more health damaging than elsewhere. But if this is the case, then the relative disadvantage of being low educated would increase as the group of low educated becomes smaller, right? And is this the case? And probably. There is support for this hypothesis in the literature. And at the same time, what does it mean today to be high educated? Well, the high educated, they don't experience the same disadvantage. So even though it is less special to be high educated today, I mean, there is more competition, the same disadvantage does not appear as we see with the lower educated. And probably we have to expect that there are other forms of inequality that will become even more important now that we cannot differentiate as much between educational levels. There might be other forms of inequality, prestige, resources, networks that will play a larger role. And then, of course, we have Sweden. As we have seen, an interesting exception to the paradox with smaller inequalities than other Nordic countries. Mackenbach, he explains this in terms of both the lower prevalence of poverty in Sweden among the four, and a lower prevalence of smoking due to snus use. So is snus the explanation of the paradox? Well, maybe to some degree. But Mackenbach, he is looking at trends in mortality. He's using education and mortality registers. And the explanations that I've put forward now really cannot take into account the deeper social mechanisms, the housing conditions, educational conditions, wealth, living conditions, and occupational factors, and so on and so on. So in order to do this, we need to look at other data. Now this is why we developed a health module, which was included in the European Social Survey Round 7. And really the first time that we have included several lifestyle factors, living conditions and occupational conditions together with health outcomes, including non-communicable diseases in a truly comparative manner in Europe. Now, I could start with, you can't really see this, you can just listen to me. One surprising finding, which goes against the paradox actually, is that overall in the European Social Survey, the population of the Nordic region reported among the highest prevalence of non-communicable diseases. So 10 out of 17 health outcomes, among the 10 out of 17, the Nordic countries scored the highest in Europe. So breathing problems, blood pressure, skin problems, allergies, and so on. Now, this poor performance of the Nordic countries revealed that the overall population health outcomes may be not better in Nordic countries than in other European countries, challenging the premise for the paradox. But our data also show that these large prevalences for chronic conditions, they do not translate into poor self-rated health. So people still feel very healthy, even if they report these conditions. So I would like to continue looking a bit into the self-rated health. So this analysis is looking at educational inequalities in self-rated health in Europe. And we have developed a way of presenting the performance of the countries. Now the red dots presents the percentage of poor health among lower educated groups. The blue dots presents percentage of the poor health among higher education groups, and the bars presents the relative differences. Now I think that should we compare countries, it's really a good idea to compare countries that have the same level of health among the disadvantaged. So this is what we've tried to do, and in this way we can really see how the various countries are comparing differently. And do these analyses support Mackenbach's findings? They do. They certainly don't contradict them, as Norway seems to be having the largest inequalities, well, by an inch, and Sweden the smallest. But the most important advantage of using these data appears when we look at the explanations. So here I want to disentangle the contribution of three main groups of determinants. So behavioral determinants, occupational determinants, and living conditions. And now here, this is probably also a bit hard to understand. Here we are trying to disentangle, so what explains health inequalities in various countries. And in the countries to the left, it is really the behavioral conditions that explains inequalities. In the countries in the middle, it's the occupational effects, and to the right, it's the living conditions. And it seems that inequalities in the Nordic countries are mainly explained by determinants that are amenable to the effects of public health regulation, so behavior factors, occupational factors, rather than determinants that are amenable to the effects of the traditional Nordic welfare state domains of cash benefits and welfare services. Of course, it's also important to take into account that actions should go towards all of these determinants and not a single one. This is just a bit of a commercial. This is some other explanations that we're providing now for Europe. This is a publication that is coming out today in the European Journal of Public Health, where we're looking at inequalities in Europe, and particularly focusing on Greece. So you might want to look it up. The publisher has promised that this will come out today. So I'm not going to present any results from that. So what can we do? How can social inequalities in health be reduced? Well, first, we have to acknowledge that there is a problem. Is there consensus now that social inequalities in health represent a societal problem? And I thought for a long time the answer was yes. Now I'm not so sure. I think the answer is far from it. I'm often now increasingly confronted with the view that we should not strive at obtaining equality in outcomes, but rather equality in opportunities. One could perhaps agree, and I can see the argument that we cannot all live equally long. But inequalities in outcomes, they point at systematic inequalities in opportunities. So even if education is free, we know that there are differences in reading abilities between peoples from different class backgrounds. And even if the healthcare system is free, we know that there are differences in the quality of care between socioeconomic groups. And inequalities in outcomes among parents translate into inequalities and opportunities among the children. So I think definitely we should still be looking at inequalities and outcomes as a means to looking at, as a signal for showing the inequalities that are persistent concerning inequalities in opportunities. Secondly, we need better, well, let me just first also say that I think that if inequalities and opportunities were to be eliminated, I think that would reduce social inequalities in health dramatically. Now, better data. Yes, of course, we need better data. We always need better data. As researchers, we will never say something different. But the complexity of our social world can, of course, never be matched by the complexity in our data. But we can get closer. For example, advances in epigenetics has brought in new perspectives and methods that I think our field should exploit more. The need for data that can incorporate interaction effects between genes and social exposures, I think, is more critical than ever. And some may think that applying the genetic information has a limited policy relevance, but I think this is not the case. Because adjusting for genetic variations in the population would make the environmental effects even more valid. And also, our DNA can even predict our school achievements. Can you imagine? In later lives, and which opens opportunities to intervene early. So at the moment, I'm involved in a new initiative as a board member of the Norwegian Research Council. And we are proposing to start a new study aiming at finding the drivers of socioeconomic inequalities in Norway. But at a high-level meeting now recently in Oslo, it was suggested that this should be a Nordic collaboration. And I'm therefore suggesting the following. The Nordic countries should join the Norwegian effort and together form the basis of a new and Nordic super study that can go deeper and further than before in determining the causes of inequalities in health and provide basis for international collaboration and better policies in the Nordic countries. I know that there are initiatives that have been made, but I also know that there are many obstacles in the work that are underway. And third, we need to combine, bridge the gaps between research, policy, and practice. In order to do that, we need to establish institutes and organizations that combine these three elements in the same organizational body. Not just collaboration is not enough. We need to work together from the start, and this is what we try to do in Chain. And of course, we need interventions. So recently, the Norwegian expert group, which I'm part of on social inequalities in health, presented 29 recommendations to reduce health inequalities. And these recommendations, they rest on many strong assumptions, such as those on causality. So it does, in other words, it does not rest on the counterfactual evidence, but we have looked at strength, consistency, temporality, plausibility, and coherence in the literature as basis for these recommendations. And they include recommendations in the fields of income redistribution, improved childhood conditions, schooling, health-promoting behavior, and access to healthcare. So I encourage you to read them. They are available. Reflect upon them, and act politically upon them. They are available already in Norwegian, and they will be published internationally in early 2019 in the Scandinavian Journal of Public Health. And it was mentioned that I have a global focus, and I do. Now, the Global Burden of Disease Study, which is the world's largest systematic effort to quantify the disease burden of a range of risk factors, involving thousands of researchers worldwide, well, they currently have a missing piece of their puzzle: socioeconomic position, inequality, social inequality. It's not part of this study. So now, we are now leading a historic attempt to bring socioeconomic position in as a determinant in this study, in collaboration with the GBD and also with the Mackenbach's group and the Norwegian Institute of Public Health. And we hope this will change government's view on the role of inequality, ultimately, which could cause governments to act. For example, in Mexico, we have seen that they've changed their health systems based on the results from the GBD study. Yes, we have challenges in the Nordic countries, but this is nothing compared to what we see beyond our borders. Now, Chain and the GBD study will be looking for collaborators next year, and I hope that there is interest in this audience also to take part of this, to bring social economy on the global agenda, where it belongs. So, I will now conclude in 3 points. First, social inequalities in health, they definitely exist in the Nordic countries, and they increase. And they will probably still continue to increase as our societies become more advanced and educated. So we will continue to be, as Johan Mackenbach would put it, punished for being successful. So those with more resources, for example in terms of knowledge, prestige, money, networks, they will always be able to use their resources for their health advantage. And this will become easier the more advanced our societies become. Still, our welfare systems are preventing the inequalities from becoming even larger. Our findings, for example, using the SS data suggest that the welfare systems are actually working in the way we hope that they should. They could always work better, but we shouldn't blame the system and think that we have to do things completely differently. We don't know how our societies would look like if we wouldn't have them the way we have them, and we should perhaps not try to find out. So I would encourage our governments to reinforce the redistributive nature of our systems. Of course, also not ignoring the individual will also in the whole picture, but I would look at the whole picture, the social gradient, and focusing on universalism. Now, secondly, a highly debated issue within public health is whether population is a result of genetics and variations in individual behavior, or whether the population health is a product of the social, economic, and cultural circumstances in which you live. We don't know this answer, and this is always an issue for debate. This is going to be probably debate here today, individual or the society, and we don't know really the proportion of the explanations. It's probably a bit of both, and that's also why we need better data on the big pieces and the smaller pieces. And I encourage the Nordic governments to collaborate on this attempt, which has been initiated already in Norway. Now, finally, and even if inequalities in health seem to be increasing in the Nordic countries, we can still be a world leader in monitoring and potentially reduce inequalities in health between, let's say, the global north and the global south. This should still be our ambition, and Chain and the GBD study will soon be looking for collaborators, as I told you. The Nordic countries, the Nordic researchers, we already have the best data, we have the best researchers, and it's a bit strange that we should use all these resources in countries where perhaps the problem is less pronounced than elsewhere. So I hope that this can be another joint Nordic effort. And this will certainly place the Nordic countries on the map as a region that care about inequality within its borders, but also between its borders. So just let me tell you that you can follow more of our work. This is actually we have a Twitter. No, this is not Twitter. This is Facebook, actually. So please, I'm going to check in 5 minutes how many new followers we have. But also the Scandinavian Journal of Public Health, which now has a new editorial group consisting of Mackenbach is there, and Marmot, and Christopher Murray, the three M's, as I call them, and many other researchers whose main aim is to reduce the health gap socioeconomically. So the Nordic countries can or should be taking the lead in many aspects, including our journals. So please follow us on Twitter, send your papers our way, and if you're interested in commenting on some of the presentations today, if you're presenting today and want to publish your presentation, I think a special issue at the start of next year summarizing some of the outcomes today would be a great thing to do as well. I think this is what I had. I'm not sure if there is any time for anything else.